Hi, everybody. Welcome to today's acid-base seminar. I thought I would go back again to what we discussed at the beginning, just to refresh people's memories as to what the chemistry is that we're talking about. So when we deal with clinical acid-base disorders, we're dealing with what happens to the bicarbonate buffer system, which is the most prevalent buffer system, both in the extracellular fluid and the intracellular fluid. And there are a number of carbonated species within this buffer system. We tend to think only of bicarbonate, or what we call the total CO2, which we'll talk about again in a minute, just because that's what's measured clinically. But actually, there are 4 different carbonated species in any solution that you bubble with carbon dioxide. And this would be true of a bottle of soda also. It's not unique to blood. It's also present in urine and all the different solutions in our body. And these equations here, these equilibrium equations, describe the interaction between the different species. Anything with a carbon on it is one of the carbonated species within these buffer reactions. So the CO2 here represents carbon dioxide that we think of when we get our blood gases, except we tend not to think of it as dissolved in solution. The carbon dioxide is not only in the air, but it's also in the aqueous phase. And there's a predictive equality between how much is in the air, the partial pressure of CO2, or what we call the partial pressure of carbon dioxide, and the amount that's dissolved. So it's called the solubility coefficient of a gas. So if you bubble a solution, any aqueous solution with carbon dioxide, if you know the partial pressure in the gaseous phase, you multiply that by 0.03 in the instance of carbon dioxide to get how many millimoles per liter there are in blood. So for instance, if we have a PCO2 of 40, that means that there's roughly 1.2 millimoles per liter of dissolved carbon dioxide in blood. So that's what this represents. And it interacts with water very avidly to form carbonic acid, the second carbonated species, which then can break up into a proton and bicarbonate, which we're all familiar with. The carbonic acid concentration is very low. It's micromolar. The bicarbonate can break up again into another proton and what is called carbonate. And this again is in the micromolar range. So we tend to ignore the carbonic acid clinically. We tend to ignore the carbonate clinically, just because relative to the bicarbonate concentration, which is around 24 millimolar, they're so low. The next largest concentration is the dissolved carbon dioxide concentration. And these two things together essentially make up what we call the total CO2 concentration. And this is what you get back from the blood chemistries. When you get your sodium, chloride, BUN, and creatinine back, the number you get with that is not called bicarbonate. It's called the total CO2. And it's also not called the CO2, because if you call it CO2, then it's confusing when you talk about the CO2 that's dissolved in the aqueous solution, which is really something different. So this really it actually represents all 4 species we talked about, but the bicarbonate and the dissolved CO2 are in the millimolar range, this being 1.2 millimolar at a partial pressure of carbon dioxide of 40, and this being 24. So the two together give you your 25 in males. Tends to be around 1 millimole per liter less in females, sometimes a little bit more than that. And the dissolved CO2 is a little bit less in females because the PCO2 is not 40, it's around 37, 38. And remember, at the time of ovulation, the PCO2 drops even further when the progesterone level goes up and women hyperventilate more. And also during pregnancy, when it's chronically decreased, this is going to be lower. And in respiratory acidosis, remember, this component goes up. So if you have someone with an elevated total CO2, it's not necessarily due to the bicarbonate. It could be that the dissolved CO2 went up and they have a respiratory acidosis. So for all these reasons, do not call what you get with the blood chemistries bicarbonate any longer if you have been up till now. The bicarbonate is there's no way to measure bicarbonate clinically. We get it from the blood gases, and it's not even measured there. It's calculated from the Henderson-Hasselbalch equation. The bicarbonate is not measured like the PCO2 and the pH are, but from the pH and the PCO2, the machine calculates the bicarbonate, and it's usually because of the dissolved CO2 difference around 1.5 millimoles per liter less than you get back from the total CO2 measurement. So just to review again, all 6 acid-base rules, which you have to know by heart in order to diagnose what's going on with your patient. Again, we don't look at the pH. We look at whether the bicarbonate or the total CO2, if you don't have the blood gases, is decreased, normal, or increased. If it's decreased, it's one of 3 choices. And if it's increased, it's one of 3 choices. So you're always dealing with a choice of one of 3 things. If it's decreased, it's either metabolic acidosis or acute or chronic respiratory alkalosis. Remember, it's not sufficient to say respiratory alkalosis. You have to say whether it's acute or chronic. That's why there's 3 things here, not 2. The fellows and residents still are saying respiratory alkalosis in the diagnosis. You shouldn't be satisfied with yourself if that's all you're saying. You need to also divide it up into acute or chronic because the acid-base rules are different. Metabolic acidosis, we only have 1 because even though we divide it up further by anion gap, the change in bicarbonate, the diagnosis of metabolic acidosis doesn't change. It's still the same relationship of the change in bicarb to change in PCO2. But for respiratory alkalosis, and as you'll see, acidosis, it does matter whether it's acute or chronic. So if you just say respiratory alkalosis, you're missing what the acid-base disorder is. You need to say in addition, is it only been for a short time or chronic? Because the acid-base rule is different. The change in bicarbonate to change in PCO2 is different. And these aren't things you can predict from knowing chemistry or physiology. You just have to memorize what occurs in humans. And other mammals have the same phenomenology. So we distinguish, we have a patient, we decide, is the bicarbonate above normal or below normal? If it's below normal, then it's either one of these 3 things, and then you have to distinguish them by knowing the acid-base rule for each. That's the thinking that you'll do throughout your fellowship on your exams and for the rest of your clinical practice. So if you look at the bicarbonate and the PCO2, there should be deltas here actually to be completely exact, but you're looking at the change from normality. Normality is always a question in medicine because you have to most of the time assume population norms if you don't know the original values in your patient. If you do, you use those as your normal values. If you don't, you assume population norms. Remember, males and females are different with their starting norms. Don't forget that. So if it's a male, you start with a belief, if you don't have the original numbers, that the PCO2 started at 40 and the bicarb at 25. If it's a female, 28 for the PCO2 and around 23 for the bicarbonate. And you answer the question, has the bicarbonate in your patient with the low bicarbonate changed roughly what the PCO2 changed by? It's not exact, it's 1.2 to 1. If that's true, then you don't have to go further. It can't be the other 2. It is a compensated metabolic acidosis. If the relationship of the change from each from normality is 2 to 1 or 1 to 5, if you want to use that, then it's acute respiratory alkalosis. It cannot be a metabolic acidosis or chronic respiratory alkalosis. And if it's 1 to 2 or 5 to 10, whatever ratio you want to use, but the bottom line is the PCO2 changed twice as much as the bicarbonate changed by. That's the concept. Then it cannot be a metabolic acidosis, and it cannot be acute respiratory alkalosis. It has to be a chronic respiratory alkalosis. So the thinking is look at the change from normality of each and decide which of the 3 it is. But to do that, you have to know these relationships, which are derived experimentally from studies done in the 50s and 60s. And you can look at those original papers if you really want to go into the history of the diagnosis of clinical acid-base disorders. It's a fascinating history, actually, which I'm oversimplifying. Or the bicarbonate could be below or above normality. If the bicarbonate is above normal, then it's either a metabolic alkalosis or acute respiratory acidosis or chronic respiratory acidosis. Again, don't just say respiratory acidosis. It's not sufficient. You have to divide it up, whether it's acute or chronic. So when someone's asking you, why is this patient's bicarbonate increased, even if you don't know anything, you say it's a metabolic alkalosis or acute or chronic respiratory acidosis. That's your answer. And then you say, now I'm going to tell you which of the three it is. And again, you look at the change. There should be deltas here to be exact. You look at the change in bicarbonate versus the change in PCO2 from their normal values, and you'll find that for every 10 increase in the bicarbonate, the PCO2 goes up by about 7. It's not quite this equality like in metabolic acidosis. And then if you see this, then the patient has a compensated metabolic alkalosis. Again, you don't have to divide this by chloride sensitivity or not, because it doesn't matter what the cause of the metabolic alkalosis is. They have the same characteristic of the change in bicarb to change in PCO2 on average. And again, it's an average of a lot of patients. In a given patient, it may be a little bit off from this. And that's when you get into questions of, is there a mixed disorder? Because remember that the lack of seeing one of these changes as predicted from the simple disorders means you have a complex disorder, or it means you have more than one acid-base disorder present. When you should say that the rule isn't applying is the subtleties of clinical medicine, which is sort of difficult. When do you say that, for instance, if this was 10 to 8, would you say that it's not a simple compensated metabolic alkalosis? You still would, but it also depends on whether there are any other clinical conditions going on that could cause another acid-base disorder. So some of this is intuition and is not precise. But for your purposes, if it fits one of these three things, then it is one of these three things. So for acute respiratory acidosis, the bicarb goes up, but it goes up 1/10 of what the PCO2 went up. And for chronic respiratory acidosis, the bicarb goes up a little bit more for a given change in PCO2. Now, again, the causal relationships are not shown here. What is the chicken and what's the egg? In metabolic alkalosis, the chicken is the bicarbonate. It went up, and then the PCO2 goes up in response. In respiratory acidosis, the chicken is the PCO2, and the bicarb goes up in response. So that's not shown here, and it really is irrelevant for the purposes of our analysis, because you're looking at a snapshot in time of the changes having occurred already. And the direction, remember, is the same for all of these too. In all these situations, you have an increase in bicarbonate and an increase in PCO2 above normality. So the direction of the change doesn't help you. All three have the same directional changes, just like in the metabolic acidosis, acute or chronic respiratory alkalosis situation, all of them have a drop in bicarbonate and a drop in PCO2 below normality. And again, the chicken and the egg is different. For metabolic acidosis, the bicarbonate goes down and then the PCO2 goes down. And in respiratory alkalosis, acute or chronic, the PCO2 changes first and then the bicarb changes. But we don't see that temporal effect clinically. You're just looking at a snapshot in time when a steady state has been reached. Okay, so each of these things is divided up into two. We've talked about the respiratory acid-base disorders. We don't divide them up further. We divide them up temporally. And the importance, though, is each of these has a different acid-base rule that you have to memorize. For metabolic acidosis and metabolic alkalosis, they have one acid-base rule that we mentioned, but independent of that acid-base rule, they're divided up further by other criteria. For metabolic acidosis, we divide them up by whether the anion gap is increased or not. And by metabolic alkalosis, we divide them up by whether they'll respond to chloride or not. Okay, so here's a 27-year-old female with the following numbers. Does anyone want to take a stab at this one? Okay, so here's the blood gases here, and there's the total CO2. Again, the bicarbonate's 14 on the blood gas, and the total CO2 is 15, which is what you'd expect. This cannot be lower than the bicarbonate. chemically, because this also contains something independent of the bicarbonate. It contains the dissolved carbon dioxide, whereas this doesn't. So if you see this is lower than this, one of them is measured wrong. Either the total CO2 was measured wrong, or the bicarbonate is wrong because the pH of the PCO2 and the blood gases was measured wrong. It's also possible that this came from arterial blood and this came from venous blood, and that you have to always think of, because this relationship of being one higher is only true if it's the same blood type. Venous blood per se has a different total CO2 and bicarbonate than arterial blood. So if you're mixing bloods, then you can't think along those lines. Only if it's the same blood or the same type of blood, and this is lower than this, do you know something's wrong? And conversely, if the PCO2 is 28, you know that the most this can be above the bicarbonate, or the most the total CO2 can be above the bicarbonate is 0.03 times this, right, which is about 0.9 plus this. So this would be 14.9, and it works out. But if this was 17, something's wrong, because the PCO2 can only contribute 0.9 millimoles per liter above this. So I hope that's clear. People don't tend to think about all these things. They look at them independent, but it's important because it's not worth thinking about what's going on unless the numbers are internally consistent. Plus, it allows you to refresh your mind as to what you're actually looking at here chemically. So we have someone with a low bicarbonate, again, becomes rote after a while. It's either a metabolic acidosis or acute or chronic respiratory alkalosis. So to distinguish the two, we don't look at the pH, or distinguish the three, excuse me. We look at the change in the PCO2 versus the change in bicarbonate from normality. We don't have original numbers, so we have to assume population numbers. It's a female, so we'll assume. And again, it's an assumption. It's a matter of belief. We don't know for sure that the PCO2 was originally 38 and the bicarbonate in the patient was around 23, 24. So we can see, just eyeballing it without a calculator or without an iPhone, without doing anything fancy, that the changes are roughly equal. So we know that if the magnitude of the changes are equal, we're dealing not with acute respiratory alkalosis or chronic respiratory alkalosis, but with a metabolic acidosis that's compensated. Okay, so these numbers are compatible with a metabolic acidosis that's compensated. We don't know whether it's elevated anion gap type or not. We'll do that next. So we look at the anion gap, and you see the numbers here. It's 131 minus 125. And so the anion gap is normal, but that is a bit confusing, because with the patient having sudden polyuria and polydipsia and the glucose being 600, what would you expect the anion gap to be? Does anyone want to unmute? Would you expect it to be a non-gap metabolic acidosis?
Hey, Dr. Kurtz. I think this patient has ketosis or the underlying metabolic acidosis. It depends on the state of the physiology. If the patient is hydrated and they're peeing out the ketones, it should produce a non-gap. But if they are not, if they're retaining their ketones, then they will produce a non-gap.
Yes, very well said, perfectly said. So the anion gap is not just due to the production of the ketones, which are organic acids, so they come in with a proton. Proton is what causes the metabolic acidosis, because it combines with bicarbonate and lowers it. But the proton has nothing to do with the anion gap creation. That has to do with what came in with the proton. And if it's not chloride, then you've got some other anion coming in that is then going to mathematically be the cause of your so-called anion gap. And so beta hydroxybutyrate and acetoacetate are coming into the bloodstream with the proton. We know the proton must have been there because we have a bicarbonate of 14, so we had to have lowered it with the proton. But then if it seems like a paradox, because if we had the proton come in with the organic anions, why don't we see that elevation of organic anions in the blood? And the answer is what was said very nicely, and that is anything and you can extrapolate this to all of nephrology. All of nephrology can be summarized by the input and output of substance X. And is there going to be a change in the blood? And it's only when you have a discrepancy between input and output that you get a change in blood. It's not just nephrology, it's all of medicine. Your CPK only goes up during a heart attack if the input of CPK from the muscles exceeds the excretion of it or metabolism of it. If the input equaled the output, your CPK never would go up. Same with lactate. During a lactic acidosis, the only reason lactate goes up is if the input of lactate into the system exceeds the excretion by the kidney of lactate. If the lactate excretion during a lactic acidosis exactly matches the lactate input from time zero, you're never going to get an elevated blood lactate. So you always, always, always have to keep in mind, and it's sort of the converse thinking, did the lack of something going up that I expected to go up occur because I'm getting rid of it via some mechanism, stool, urine, whatever it is, dialysis? Have I created an output, or is there a spontaneous output that is matching my expected input and my expected elevation? So it's similar to, let's say, a patient with sarcoidosis or vitamin D intoxication who's hypercalciuric but not hypercalcemic. If you see that, you know that the output of calcium in the urine is matching the input, and that's why the blood's not going up. You only get an emia, so-called emia of anything, if you have a discrepancy between input and output. So that's concepts that you really, really, really need to take to heart, because it will allow you to interpret all sorts of funny things that are occurring in medicine. There's nothing unexpected about it. You have a bathtub with a drain running all the time. You can think of the input as the tap running into the bathtub, and the drain is the output, urine, stool, dialysis, whatever it is. And the blood and the water level in the bathtub is only going to change when you have a discrepancy between the two, when they're unequal, whatever the direction of each is. The inequality creates the change in the system. So that's what's going on here, as was said. If you have a patient that can excrete the ketones at the same rate they're coming in, your blood level's never going to go up. And that tends to occur. So the question is, what type of patient would we see that in, and why don't we always see it in ketoacidosis? Why is it occurring here but not all the time? What's unique about this patient that isn't occurring in others? And what's occurring in this patient that you don't always see is that the patient has a good GFR, as reflected by the creatinine of 0.9 and the BUN, and therefore the patient has the mechanism for excreting ketone. It requires a normal GFR. They come through the glomerulus and then they're excreted. They're not absorbed well by the proximal tubule. So the excretion in the urine is really dependent on what the GFR is. Now, that GFR can be spontaneously normal because the patient wasn't vomiting a lot or was given volume, or the GFR was corrected therapeutically by the patient suddenly drinking a lot of tomato juice or salt water, or was given an IV. Whatever it is, we know that the GFR must have been very good from the beginning. If the patient didn't see a doctor, then we know likely they weren't vomiting a lot and they didn't have a lot of output in the urine from the glucose load coming through. They didn't have a lot of osmotic diuresis. Now here it's a bit strange because we do have a history of polyuria, polydipsia. So we know we had polyuria from the osmotic diuresis. It probably wasn't of sufficient magnitude. The other possibility, it was of great magnitude, but the patient was just compensating by drinking a lot. And so compensated and remained pretty euvolemic. Whatever the cause, we know the GFR is good. Now, it can also occur in the hospital in a temporal way. The patient can come in volume depleted, pre-renal failure, and their anion gap's elevated, and then you start an IV. You start an IV, you improve the GFR, and now you dump all the ketones in the urine, and the anion gap drops. That's important because, especially in the ICU and renal fellows and residents, they always interpret, not always, but many people interpret the magnitude of the anion gap. They equate that with the severity of the ketoacidosis, and not just the ketoacidosis, but the severity of the input of ketones and protons into the blood. And that's not true, because the anion gap and the ketone ketone level vary with the output. And so if you have a patient with a constant input of protons and ketone bodies who was volume depleted, and therefore the ketones built up in the blood, and now you start an IV and the anion gap drops, and you find ketones in the urine, that would reflect your hypothesis. It isn't that you corrected the ketoacidosis at all. You did nothing on the input side. All you did was allow the ketones to be dumped. So that's very important too. Don't interpret the drop in the anion gap to be equal to the ketoacidosis being corrected. That's only true if the anion gap got better and the ketones weren't dumped in the urine. Well, how can that occur? How could the ketone level or the anion gap level be improving, but you find no ketones in the urine? Well, that's the other way the anion gap can return to normal, and what's going on there is there is a true improvement in the ketoacidosis, but it's not the anion gap and the ketone body measurements in the blood are not normalizing because of dumping in the urine, which has nothing to do with the ketoacidosis improving. What's happening there, where you don't find the ketones in the urine, and you have to make that distinction when you see the anion gap dropping or when there's no anion gap to begin with, you have to immediately answer, is it because of ketones in the urine or not? So you measure the ketones in the urine, they're not there. Well, how are they decreasing in the blood? How's the anion gap getting better? It's because the organic anions are being converted into bicarbonate. That's what happens. Remember, anything with carboxyl groups, whether it's beta hydroxybutyrate, acetoacetate, lactate, citrate, acetate, doesn't matter what it is. They have carboxyl groups that get neutralized in the Krebs cycle and converted to bicarbonate. Same thing as we talked about a number of times with alpha ketoglutarate. That's what normally occurs all the time in our kidneys to match our daily hepatic proton load of hydrochloric and sulfuric acid from the diet we eat. Kidneys making new bicarbonate from the alpha ketoglutarate, which has two carboxyl groups on it in the Krebs cycle. Well, that occurs with any organic anion. Same with ketones. And so what you would see there, though, is something you don't see with the dumping of the ketones in the urine. With the dumping of the ketones, the bicarbonate's not changing. In fact, it's bad. You've lost this source of new bicarbonate. It takes paradoxically longer for the metabolic acidosis to correct in patients with ketoacidosis who are euvolemic, who have dumped all the potential source of bicarbonate in the urine. So part of your brain thinks, oh, their anion gap's not elevated, they're doing better. Well, I find all the ketones in the urine. Are they actually doing better? Well, they're doing better from a volume point of view, but they're not doing better from having a substance that can be converted into bicarbonate. The ones with the elevated anion gap, when they're given insulin and the ketoacidosis is corrected and shut off, actually now have a ton of organic anions in their blood that in the Krebs cycle of their cells can be converted into bicarbonate. They don't need as much bicarbonate, these patients, compared to the ones that are euvolemic and dump the ketones in the urine. So all these things you need to think of when you see a patient with ketoacidosis. The other thing you might see is that the bicarbonate fell, let's say, by 10, but the anion gap is only like, let's say, 14, 15. It's only up a little bit. And then some people erroneously call that a gap and a non-gap metabolic acidosis. That's not true. It's all an anion gap type metabolic acidosis. It just becomes hyperchloremic or non-gap when the ketones are dumped in the urine, right? You have to maintain electroneutrality. Otherwise, your urine or your blood would be sparking. So and I'm saying that just as a partial joke, but you have to have equality of positive charges and negative charges. So when the ketones, which are negatively charged, are dumped into the urine, chloride goes up equimolar. And so you end up with a high ultimately it would go up whatever it needs to, whatever the bicarbonate dropped by. So the bicarbonate dropped by 10, you dump all the ketone bodies, the chloride's going to go up by 10. If your bicarbonate dropped by 10, your ketones are only partially excreted, the chloride doesn't go up as much, but the total of the three stays the same. The total negative charges stays the same. So the fact that the anion gap doesn't go up as much as the bicarbonate fell doesn't mean you have diarrhea or RTA or another non-gap metabolic acidosis. It's just a picture of partial hyperchloremic because you dumped the ketones, but the cause of everything is still an anion gap metabolic acidosis. And that's confusing in the literature because you'll see some people talk about there's a partial hyperchloremic pattern, even though the cause was an organic anion metabolic acidosis. The pattern seems to be a mixture of both, and that can be confusing too. The point is to talk about the cause, not the pattern in the blood. The cause is still a proton coming into the blood with an organic anion. And this just sort of pictorially shows in a balanced sense what occurs. You have a proton coming in with an anion. The anion can come out depending on the GFR. Remember that you don't just have this going on. Your kidney is recognizing this and trying to generate more bicarbonate. If the proton input into the blood would be equally matched by the enhanced bicarbonate production from alpha-ketoglutarate, essentially, you would never get a metabolic acidosis either. So if you take like the thought experiment, let's say a patient has protonated lactate coming in because they just had a heart attack, and you expect the drop in bicarb from the proton, and you expect the elevated anion gap from the anion coming in. If in our thought experiment, the anions were excreted at the same rate they were coming in, and if the kidney could rev up its new bicarbonate generation above normality to match the proton load with lactate, you would never even see a fall in bicarbonate. So this isn't something that people think about, but you only get a drop in your bicarbonate when the proton input exceeds the ability of the kidney to enhance its new bicarbonate generation, which it does do. It does that in every metabolic acidosis. And we know it does because the urine ammonia goes up. And remember, the ammonia comes from that alpha-ketoglutarate metabolism reaction that I showed from the glutamine conversion to new bicarbonate. Ammonia is made. And we know that occurs empirically. So we know we're making additional new bicarbonate. But if you develop the metabolic acidosis, you know that there was an inequality between these two. So you should go through this kind of thought process also and teach the residents. Again, it isn't just input-output for the anion. The metabolic acidosis develops clinically because there's an inequality between the input and the new generation of bicarbonate. Okay, so here's another patient. I think we've talked about glue sniffing before, but there's some subtleties that I'll try to emphasize now. And what you see here is this compensated metabolic acidosis picture. Again, we can eyeball it. We can see right away that changes are roughly 1-to-1. So it's a compensated metabolic acidosis. And we measure or we calculate the anion gap and we see it's normal. So what's going on here? We have some things that would make us think that there might be RTA. We have a non-gap metabolic acidosis. We have a high urine pH. We have things here, though, that go against it. Well, the urine anion gap's positive. So you would think and this is really the crux of the question, which I'll open up to the floor in a second. So we have a high urine pH. Okay, is it RTA? Actually, it turns out that the most common cause of a non-gap metabolic acidosis with a high urine pH is by far diarrhea. Way more common than distal RTA with hypokalemia. We'll talk about why diarrhea with hypokalemia causes a high urine pH a separate time. But it's statistically by far in an exam, if you get a patient like this without any history, pick diarrhea. But there's some funny things going on here. The urine anion gap is positive, which, if you recall, was the historic way of assessing the urine ammonia. The point here, though, is it's positive, which you would say in previous years, until we now, at least at UCLA, can measure the ammonia, you would say the urine ammonia is low. Remember, if the urine anion gap with ammonia presence usually negative, it's like -20 to -70, 80. If it's above +20 on the positive side, there's little ammonia. But yet, when we measure the urine ammonia, which we can do at UCLA now, comes back at 90, which is above normality. If I measured the urine ammonia in all your urines, I get something like 30, 40, 50 millimoles per liter. And in this patient, it's 90. So how is it possible that we know with metaphysical certitude, we have a lot of ammonia in the urine, actually more than normal. But our urine anion gap is positive, which how do those two things go together? So this case brings up the teaching point that the urine anion gap is not just a reflection of the unmeasured cations, which is essentially NH4 plus. Again, there has to be equality of negative and positive charges. So just like blood, the urine anion gap is equal to the unmeasured anions minus the unmeasured cations. And you can flip the equation. That's because sodium plus potassium plus unmeasured cations equals the unmeasured anions plus chloride. We're just flipping the terms to opposite sides here. But the important point is that the sodium plus potassium minus chloride does not just reflect UC, which is NH4 plus. It's the unmeasured anions minus UC. So if we know that the anion gap is 40, we can plug in the 40, and we know with certitude the unmeasured cations are 90 because we measured the ammonia. That tells us that the reason for the discrepancy is because the unmeasured anions are 130. Now, normally, the unmeasured anions are much lower than this. That's why you end up with a negative term on this side. It's because the unmeasured anions in normal human urine are less than the ammonia concentration. So you end up with this being negative. In our patient, we have a very high unmeasured anion concentration, and that's causing the discrepancy between the expected and what the actual measured ammonia is. So what's going on? What's going on with glue sniffing that might elevate our unmeasured anion concentration? Well, it turns out we'll back off a little bit and start off by saying, well, what's the cause of the metabolic acidosis altogether? We know it must be a proton, right? The proton is what's causing the drop in the bicarbonate, but what else is going on? Well, what else is going on is there's hippurate coming into the blood. Glue sniffing with toluene, you end up creating hippuric acid. So the organic anion is hippurate, and the proton comes in with a hippurate. Proton causes the metabolic acidosis. The hippurate, you would think, would be elevating the anion gap in the blood. But we have the same thing going on with this patient as we had in the volume replete patient with ketoacidosis. We have a situation where we have anions, in this case, not ketone bodies, but hippurate coming in, and they're being excreted in the urine. So it turns out that the kidney does not have a good way of reclaiming hippurate. And so they come out in the urine, and that's what our UA is, the unmeasured anions. We have a hippurate concentration of about 130 millimoles per liter. And you can see the math works out. Well, it must work out just based on the numbers. We're just flipping our thinking. So you have 130 here, or 130 here minus the ammonia. So the hippurate minus the ammonia is equal to the urine anion gap. So the reason the patient's urine anion gap is positive here is not because there's little ammonia. In fact, there's more ammonia than normal. It's because we have an increase in the unmeasured anions that increased to a greater extent than the urine ammonia did. So we end up with a positive number here. So the reason this case is brought up is it's the same thinking in a certain sense as a euvolemic patient with ketoacidosis. Even though you have an organic anion coming into the blood with a proton, you end up with a situation where you have a non-gap metabolic acidosis. The reason's different. The hippurate's always excreted, tends not to vary as much with the GFR. Although if you had a patient with severe CKD, you would have an elevated hippurate concentration too. Okay, so again, the urine ammonia is elevated. That's nothing that wouldn't be predicted. And if you don't have CKD and you don't have distal RTA and you have a normal kidney that can metabolize glutamine, you're going to have, in the presence of a metabolic acidosis, a high urine ammonia concentration. You see it in diarrhea. Any extrarenal cause of metabolic acidosis where the kidney is normal, you're going to have the kidney trying to prevent that metabolic acidosis from occurring by generating more new bicarbonate from glutamine than it normally does. And again, the fact that we have a metabolic acidosis means that despite the elevated new bicarbonate generation, the proton input exceeded it. So this is greater than this, even though this is elevated and this is elevated. This is increased greater than the kidney can increase its new bicarbonate generation. Now, again, what I didn't say was that the ability of the kidney to do this will depend on how severe the CKD stage is. In ESRD, you can't generate any new bicarbonate. That's why patients with ESRD get a metabolic acidosis. They can't match their daily hepatic proton load. And by inference, they can't respond to an extrarenal metabolic acidosis either. Patients with ESRD or CKD who get the same proton load as me and you are going to have the exact same proton load, are going to have a worse metabolic acidosis, not because the proton load's any different, but because they have a difference from you and I in their ability to compensate for that by generating additional new bicarbonate from glutamine. So the bicarbonate you end up with is not, again, just due to the proton load, it's due to how increased the kidney can elevate its new bicarbonate generation. So you should always think of that also. The bicarbonate you end up with is not just because of the input side. It's the same concept as the anion gap. Always think of either outputs or what else is occurring to compensate for it. And conversely, you can have a patient with lactic acidosis with a normal bicarbonate. And it's not because you don't have a proton load in an absolute sense. It's because the kidney is able to match that increased proton load with additional new bicarbonate generation. So input output. Okay, here's a case of a 58-year-old male. And we don't have any clinical information, but we look at the PCO2 and the bicarbonate, and we see that the bicarbonate's elevated and the PCO2 has gone up 7/10 of what the bicarbonate went up. We know right away it's a compensated metabolic alkalosis. And the only thing we have to answer now is what kind. Well, even without measuring the urine chloride, the patient's got prerenal failure. So right away, you know the patient's volume depleted, or most likely volume depleted. And therefore, it's most likely due to one thing on an exam. It's someone vomiting. This would be the most common statistical cause of these numbers, even if you never looked at the chart or got any history or clinical information. That's the lever you would pull. And again, when it's the stomach causing the situation, you have to remember, as we talked about before, the molecular machinery in the parietal cell of the stomach that leads to the generation of bicarbonate. So every proton coming into the lumen when you're vomiting creates a bicarbonate ion, which then leaves not into the lumen, but into the blood stream that's leaving the stomach via a protein called AE2. And that's what then goes into the gastric vein, gets into your IVC, and elevates the bicarbonate, potentially only, again, if you don't excrete it. It's the same thinking that this bicarbonate load will not be manifested as a metabolic alkalosis if you dump it in the urine. So again, we talk about why in metabolic alkalosis are you not dumping loads, and that's called the maintenance phase. So there's the generation phase, which means where's the bicarbonate coming from, and there's the maintenance phase, which means there's things going on in the kidney preventing it from being dumped into the urine, as you would expect if there was no maintenance phase. And there's three parts of the nephron that contribute to this. One, there's prerenal failure, so there's less bicarbonate coming into the urine per unit time. The proximal tubule for any given load is hyperabsorbing bicarbonate above its normal level because of the sympathetic nervous system and angiotensin II, changing the maximal transport capability of the proximal tubule. And we won't get into what's occurring at a molecular level, but just know that in a global sense, the proximal tubule for any given load absorbs more of it than before. And there's also decreased secretion of bicarbonate in the cortical collecting duct, which involves a protein called pendrin. Pendrin only works if there's chloride in the lumen. As you lower the luminal chloride concentration, pendrin stops secreting bicarbonate. And that's shown here. These are just showing the different cell types in the cortical collecting duct, and it's not all inclusive. There's even additional cell types. But the one we're talking about here in metabolic alkalosis is the type B intercalated cell that secretes bicarbonate in exchange for chloride, and it's called pendrin. It's called pendrin because it's involved in what a disease called Pendred syndrome, which is a thyroid disorder since this transporter is also in the thyroid and is involved in hypothyroidism. But it's the same protein that the kidney utilizes to secrete bicarbonate, but you have to have chloride in the lumen. If you don't have chloride in the lumen, it won't work. And so this will contribute to the maintenance phase, but it'll also contribute to the therapeutic phase. If you give chloride, you will now allow chloride to be seen by this cell, and now bicarbonate gets dumped into the urine and will decrease in the bloodstream. So when we give chloride, we're stimulating the type B intercalated cell to secrete bicarbonate. It's not the only thing chloride does, but it's the reason we talk about chloride and not sodium or potassium or some other anion. It's because this cell requires chloride to be present above a certain concentration for it to drive bicarbonate thermodynamically into the lumen of the tubule here, and then to be excreted in the urine. Okay, I think because of the time, we'll stop here and we'll continue on in the next talk. So thanks again for joining. Does anybody have any questions about we talked about? Today's talk reiterated again and again the concept of input and output in different clinical scenarios, and constantly thinking of that when you're trying to interpret what goes on inside the box in the bloodstream. Don't just think of the input or the output. Think of them always coupled to each other. And if you do so, and you know what factors determine the input versus output of different substances, not only in nephrology, but anything you measure in the blood, you'll be able to interpret what's going on in your given patient with more precision. Okay, everyone, have a great day. Thanks for joining.